Welcome to the Doctor's Corner with Dr. Kline and Jonelle Elgaway. And now your host, Jonelle Elgaway and Dr. Kline.
Good evening and welcome to the Doctor's Corner on CAW 360 Network. I'm your host, Jonelle Elgaway, and co-host Dr. Kline. Welcome, Dr. Kline.
It's good to be on the show this evening. You'll have to excuse my kind of raspy voice. It's too many cigars. It's just done it to me.
Not again. I thought it was the donuts, maybe.
Well, no, that's another problem I
have. Tonight we have special guest Dr. Jeffery Fudin with us to talk about pharmacology. Welcome, Dr. Fudin. How are you this evening?
I'm great. Thank you very much for having me on the show.
Well, we're happy to have you. I'm going to share some important information about tonight's program. There are two ways to listen to tonight's show: through our website, which is www.cawnation, or YouTube channel, The Doctor's Corner. Dr. Kline loves to hear from you and answer your questions from our mailbag. If you have future mailbag questions, you could send them to my assistant, Jess Stewart. Her email is jstewart@caw360.com. If anyone would like to call in with a question this evening, you can do so at 415-915-2291. Before we start, Dr. Kline, is there anything newsworthy that occurred in the last week that you'd like to share with us?
Yes. As you know, there are a significant number of people killing themselves because their disease is so bad. They sit around in pain all day that they figure that life is not life anymore. And it's just absolutely horrible that this happens. Doctors are not prosecuted for this. They're prosecuted when their patients commit suicide for other reasons. But being responsible, in my view, of someone's death really should be considered a crime, and that's my personal opinion. But there are two doctors now up on charges for contributing to the death of their patients when they took them off their medications, basically for no reason. So I think that's big news. I'm sorry, I belong to the brethren, but I cannot support doctors who do anything at the request of the government. That's not what we do as doctors. During the Civil War, the Union physicians went over to the Confederate side and helped out the doctors. I suppose that could have been prohibited, but doctors have always been independent, physicians have always been independent, and they need to stand up for the rights of their patients. The government has really come between doctors and their patients. So we'll see how it turns out.
Okay. Dr. Fudin, do you have any newsworthy information that you know about that you'd like to share with the audience for this week?
Well, I guess an important upcoming news is going to be the initiation or implementation of the new CMS Guidelines, which start on January 1st. And that, of course, is going to create a lot of commotion because it's going to require soft and hard edits on prescriptions. So, for example, Medicare patients, when they present the prescription at a pharmacy, if their cumulative morphine milligram equivalent dose per day, when adding up all of their opioids, reaches or exceeds 90 milligrams per day, regardless whether or not it was an individual prescription, it will trigger a fill alert, and what will happen? The prescriber who writes the prescription will be alerted and will be contacted by the pharmacy, even if the prescription is below that threshold. So that's going to be a required call. If it reaches 200 milligrams, it's a hard stop. So that's happening as of the first. The other thing that's happening is there's going to be a limit of a 7-day supply for opioid naive patients. And it'll be interesting to see how this all turns out after the first.
Okay. Let's take a few questions from our mailbag. Jesse Ray wanted to know, why did our government and CDC lump all overdose numbers in together to overinflate them? Then they create the brutal CDC guidelines leading to laws to hurt us chronic pain patients.
They made a mistake. Go ahead, Dr. Fudin. You're our guest. You get to go first.
Yeah. I can't tell you why they did it, but what I can tell you is that the CDC website and many journalists and mainstream media often quote there's 60,000 drug deaths a year, and the headlines usually talk about opioids, and then following the headline it says there's 60,000 drug deaths per year, but those 60,000 drug deaths, or now 72,000 drug deaths per year, include anticoagulant therapy, antidepressants, gabapentin, pregabalin, soma, benzodiazepines alone, and or combined with or without opioids. So that question, the answer to that question is I don't know why they did it, but they did it, and it's incorrect.
Okay.
I agree with that.
We have another question from the mailbag. What is the difference between Schedule 2, 3, and 4 concerning pain medication?
So the schedule differences, there's 5 different schedules. So the lower the number, so number 1 are drugs that do not have any medicinal use according to laws. So for example, in this country, heroin is not approved as a prescription drug. Heroin is diacetylmorphine. Heroin does have medicinal use. And in fact, in the UK, heroin is available as a prescription, but Dilaudid is not available as a prescription. And interestingly, Dilaudid is about 10 times more potent than morphine, and heroin is 7.5 times more potent. So we kind of got the better deal. Also, Dilaudid or hydromorphone is more well tolerated. But in any case, Schedule 1 drugs are those that are considered not to have medicinal use. And at present time, the FDA considers marijuana to be a Schedule 1 as well. Schedule 2 are considered to be those drugs that have the highest potential for abuse or misuse. And these are not just opioids, they are other drugs as well. So Schedule 2 would include things like morphine, methadone, prescription fentanyl, and various other medications in the opioid class. And also in Schedule 2 are things like testosterone supplements, because testosterone has a high incidence of abuse for bodybuilding. Things like amphetamines are Schedule 2. Schedule 3 are drugs that are thought to be abusable, but have a less abuse potential than those in Schedule 2. And things like that would include Tylenol with codeine, and various other medications, certain barbiturates. Phenobarbital would be a Schedule 2, but butalbital, which is also a barbiturate, is Schedule 3. Phenobarbital is Schedule 4, or maybe Schedule 5. I can't actually remember. So Schedule 4 has even a lesser abuse potential, things like tramadol. And then Schedule 5 has the least abuse potential, but is still abusable. And that would be something like codeine, small amounts of codeine in cough syrup, which are refillable. So Schedule 3 through 5 are all refillable. Schedule 2 is not refillable, and Schedule 1 is not available for medicinal use in this country.
So you can't. I've always wondered how the federal police department determines the abuse potential of drugs, but we don't need to go into that. It's just a curious phenomenon that the police department has been put in charge of all the issues concerning me prescribing. It all stems from the Richard Nixon law, 1970, the Controlled Substance Act. And we now know, after a confession from John Ehrlichman, 24 years later that Nixon started this law for political reasons, had nothing to do with health, had nothing to do with addiction. He wanted to nail his enemies, that he could round them up on drug charges, because you cannot in this country round up people for their political beliefs. So it was a very clever thing. And here we are today, many years later, struggling to run our practices each day under the rules of the Federal Police Department. So that's at this point all I have to say about that.
Okay.
But the scheduling is the police do the scheduling. Like, how do they know? But moving on.
Before we get into tonight's topic of pharmacology, we're going to just take a quick call. Caller from area code 845. What's your question for Dr. Kline or Dr. Fudin?
Yes, how you doing? My question is, with all the hospitals now are becoming teaching hospitals, and obviously, the doctors of past generations who are not so much afraid to prescribe pain medications to their patients, these new doctors are being taught that almost every patient needs to start out, no matter how severe an injury is or an illness is, at the very bottom, and patients are going without adequate pain relief. So if the government should come back and release a little bit of these strictures on prescribing, as these new doctors come in and they're already programmed not to prescribe properly for pain, whether or not it's a minor injury or whether or not it's something like cancer, how is that going to factor in and become an issue? Or is that not creating where all of a sudden now we don't have medical staff that knows how to handle pain, and we're more or less recreating an issue that we have right now by not prescribing properly for these pain patients?
Dr. Fudin.
So this is Dr. Fudin. First of all hospitals are not becoming educational institutions. In order to be an academic hospital, there's a number of factors that need to be met. But that aside, I think that your point is very well taken. Programming doctors, young doctors, to inadequately treat pain is a problem. But the truth is, doctors, pharmacists, and most clinicians have been poorly educated in pain at the very beginning, in the middle, and today. I mean, it has always been poor. So, and I'll give you an example. We know that chronic pain, now you're talking about acute pain, but for instance, we know that chronic pain affects more people than cancer, heart disease, and diabetes combined. I can tell you that when I was in school, heart disease alone was 6 to 8 weeks. Cancer was 6 to 8 weeks, and diabetes was 6 to 8 weeks. Pain management was about 2 hours and only involved cancer pain. And that's pretty much the status quo today. So if you're in a pharmacy college or you're in a medical college, very few schools spend more than 2 to 4 hours teaching pain management. And the truth is, it most often is taught by people who don't have expertise in the subject to begin with. So I agree with you. I hear your concerns, and you are absolutely correct. But unfortunately, it's probably no better or worse now, education-wise, than it was 10 years ago, 20 years ago, or 30 years ago.
So why don't you and I do an educational series? You can give them the facts, and I'll do the ranting.
Yeah, I spend an awful lot of hours each week teaching pain management, that's for sure.
Can I ask one more question?
Go for it.
All right. My question is, now with the opioid, what most people are, declaring a hysteria, whether or not it's on TV continuously, in schools continuously, on the internet continuously, and a lot of the numbers are falsely reported, are kids that are growing up. We know that kids, the reason why most of them get into drugs, whether or not is they want to experiment, so on and so forth, are they more or less kind of, edging kids, to say, daring them, whether or not it's really as bad as they say it is, I mean, we've talked to our kids about drinking, smoking. They do it anyway. So if we're continuously dangling these opioids in front of them, telling them that you're going to be an addict, are we more or less, playing with fire, trying to tell these kids, we dare you to see whether or not you will or you won't? I mean, kids are foolish. They don't know, and parents don't always properly educate their kids. More or less, they're relying on the school systems and the media to do this, and we know that this isn't being done properly.
I mean, it's really hard to know. I can't predict that. But what I can say is this: whether it's children, adolescents or adults, it is clear that prescription opioids have come way down in the last 5 years, and the doses per day that are prescribed have also come way down, and opiate overdose have gone way up. So we don't really have a prescription opioid crisis anymore. What we have is an illicit opioid crisis. And I think that, to your point, a huge problem is that whereas before, not that I'm advocating for this, but whereas before people took pharmaceutical drugs because they thought they were safe, and believe me, I'm the first one to say that they're not safe, they had fixed doses in them. And now what's happening is they're going to heroin because pharmaceutical drugs are less available. And to make matters worse, if they're regular users of heroin, and now all of a sudden they're being laced with fentanyl derivatives that are not pharmaceutical fentanyl, there's no way of knowing how much drug is in that batch of heroin, or if there's any heroin in there at all. And that's one of the reasons why so many people are dying. Again, I want to make it crystal clear. I'm not advocating that anybody should be abusing any of these drugs, whether they're pharmaceutical grade or not. And in fact, there's been a lot of pharmaceutical lookalikes that contain cocaine, various other hallucinogens, and fentanyl derivatives. So it's a problem all the way around. But I think that people that are exposed to these drugs earlier, one of the problems is whether they have experience using opioids or not. They're in higher danger now than they were before we had these fentanyl analogs on the street.
All right. Thank you very much.
Welcome.
Thank you for calling in. Thanks. Well, we're going to go ahead and get into our program tonight. Dr. Fudin, I saw a recent article you wrote on Log Practical Pain Management, where you state there's an update made to the ppm opioid calculator to remove conversions to and from buprenorphine. Can you explain why bup is removed and like pain medications like oxycodone isn't?
Oh, yeah. Okay, so that's a great question. I guess I probably should have brought that up at the beginning when you asked me about new news. So, yeah, that's a fantastic question. So, many years ago, I think it was in 2012, I think, I helped Practical Pain Management to establish an online opioid conversion calculator. And at the time, I was kind of reluctant, and the reason I was reluctant is because I'm not a firm believer in morphine milligram equivalents to begin with. And just to give you some background on this, when the morphine milligram equivalents were first established many years ago, they were not based on toxicity. Basically, what morphine equivalence was about is if you look at two different drugs, what dose of each of these drugs would you need in order to establish a similar effect, a similar analgesic effect? That's what morphine milligram equivalents were all about. What's happened in the last few years is that this has kind of been twisted by the CDC, managed care organizations, states, and federal government to say that a morphine milligram equivalent is a comparison of toxicity of these drugs. And that was never the case, never, ever the case. And so two drugs that have a similar effect on analgesia don't necessarily have the same toxicity. So that's some background. Now, when I helped establish this, write this calculator, I took very significant steps to make sure that there were certain warnings in there. So, for example, at the time that this was written, Tylenol with codeine, oxycodone with acetaminophen, hydrocodone with acetaminophen. They were all available with 500 milligrams of acetaminophen per tablet. That has since changed, and now they're only available as 325 milligrams. So one example of a stopgap in there is that if somebody tried to convert, let's say, plain oxycodone to Tylenol with codeine, or let's say Lortabs, which is hydrocodone and codeine, you would get to a certain milligram strength, and it would tell you stop. The amount of opioid you need exceeds the acetaminophen toxicity. So if you can imagine, so let's say you needed, 16 tablets a day of Lortabs in order to equate to a certain oxycodone dose. The calculator would stop you and say it's too much acetaminophen. You need to add a different drug. So there was a lot of things we had in there. One thing we had in there was for methadone, because conversion of methadone is so complex and so potentially dangerous that in order to use the methadone portion of that calculator, you had to answer a bunch of questions. You had to check off boxes to say that you recognize that methadone represents 2% of all prescriptions, but that 33% of all opioid deaths are methadone. You had to check off that you understand about the drug interactions and that sort of thing. So now with that background, I'm going to get to your question. The question, I think, was around the recent publication in Practical Pain Management of why we took out morphine milligram equivalents or conversions for buprenorphine, and we didn't take them out for, did you say oxycodone?
Yeah, as an example.
Okay.
Yeah.
Okay. So great. Okay. So here's the reason why. So oxycodone is considered to be a full agonist opioid. In other words, it combines with these receptors called mu receptors, and it elicits a response. And that response will be analgesia, it'll be euphoria, it'll be sedation, it'll be constipation, respiratory depression, and all the typical kinds of side effects that you have from things like oxycodone, morphine, hydrocodone, whatever. All right. So that is a full agonist opioid. By definition. Buprenorphine is what we call a partial agonist opioid for the mu receptors. And the mu receptors are the receptors that are responsible for all the things I just talked about, euphoria, constipation, that sort of thing. But it
now,
also...
for the audience, an agonist is a drug that works positively. Go ahead.
So something that has agonist activity basically elicits a response. You could have agonist activity that elicits a response that you don't want as well. So for example, opioids are agonists at the mu receptors. They agonize or they stimulate mu receptors in the gut, and they cause constipation. Well, that's not something we want, right? But they also agonize receptors in the central nervous system, and they cause euphoria and pain relief. That's something that we do want. All right, so that's an agonist. So buprenorphine is a partial agonist/antagonist, which means that it has a little bit different chemistry, the way it combines with opioid receptors for its agonist activity, and it also inhibits other opioid receptors called kappa receptors. But if we just focus on mu, for example, the buprenorphine has a plateaued effect or a ceiling effect on respiratory depression in comparison to full agonist opioid. So something like oxycodone, as the dose continues to go up, the risk of respiratory depression goes up. Analgesia goes up. So all the effects of a full agonist increase as the dose goes up. With buprenorphine, you get to a certain point, and you won't get any more CO2 or carbon dioxide accumulation in your blood. So it's safe from that perspective. But the other thing is that buprenorphine has a higher binding to the mu receptor than oxycodone does, than morphine does, than almost any drug does. So what happens is if you're on buprenorphine and it's occupying those receptors, think of it as a game of musical chairs. Each chair is a mu receptor, and the people sitting in that chair, or the people that are walking around those chairs as the music are playing, are the opioids. once the buprenorphine sits down in that chair, it doesn't get up. It doesn't get up. When the music starts and it gets up, the buprenorphine is going to grab the chair again. So morphine has very little chance of occupying that receptor once you take buprenorphine. Now,
does that make buprenorphine a better painkiller? A lot of people are concerned, and they write me and say, the doctor wants to put me on buprenorphine. And so my answer is, I'm not real sure, so we have an expert. So how is buprenorphine as a pain medicine? What do we tell people when they're concerned?
So that's a great question, but let me just finish the answer to this question. So one of the reasons, Jonelle, why we took the buprenorphine off of the calculator is because if you have a patient on morphine and you replace the morphine with oxycodone, that's doable. You need to do it carefully, but it's doable. If you have a patient on oxycodone and you want to convert them to hydrocodone, that's doable. They're both full agonists. But if you have a patient on oxycodone and you give them buprenorphine is going to grab the receptor and displace oxycodone. And oxycodone there's not going to be a lot of receptors available for the oxycodone to take back. And because of that, the patients will suffer withdrawal symptoms. If you're on buprenorphine and you want to replace it with oxycodone is not going to be able to get to those receptors because buprenorphine has such a high binding affinity for those receptors. And so that's the reason why we have disallowed buprenorphine as a conversion, because it's not like comparing apples to apples. It's a very, very unique opioid pharmacologically. Does that make sense?
Yes, absolutely.
Okay. So now to answer your question, Dr. Kline, the short answer to your question is it depends. Dr. Kline's question was, does it work as well for pain as something like, let's say, oxycodone or morphine? So I will tell you there were studies as early as some great studies as early as the late 70s, 1978, that looked at buprenorphine intravenously in the surgical setting in major surgeries, abdominal surgery, OBGYN surgery, hip replacements, things like that, orthopedic surgeries. And those surgeries all showed that an equivalent typical morphine dose surgically, IV, to buprenorphine IV worked as well or better in all cases and lasted longer because it has a longer half-life. So at least in the acute setting, we know that buprenorphine works as well or better. In the chronic setting, I believe that it does and it can, but some patients respond better to some opioids than others for various other reasons. Very low doses of buprenorphine will not work as well as oxycodone. So, for example, if you look at the Butrans patch, the transdermal buprenorphine, it lasts for 7 days. So I'm going to walk you through this because I want to give you an idea of how different these drugs are. So the Butrans patch is about 15% absorbed through the skin. 15% absorbed, and the highest dose that you can get in this country is 20 micrograms per hour, or what they call a 20 milligram patch. 20 micrograms per hour over 24 hours multiplied by 15% gives you about 72 micrograms of buprenorphine in a day. That dose is minuscule, absolutely minuscule, and that dose will not come close to something like oxycodone, hydrocodone, or morphine. Now, the other buprenorphine product that is FDA approved for pain management is Belbuca, which is a buccal film. That one is a small little, almost the size of about the quarter of the size of a chiclet piece of gum, and you put that on your cheek between your gum and your cheek, and that's dosed every 12 hours. That's about 50% absorbed. So the smallest dose of that is 75 micrograms. So the smallest dose of that, so 50% of the 75 micrograms twice a day is 75 micrograms. So what I'm saying is the lowest dose of Belbuca is about equivalent in the amount that gets absorbed as the highest dose of the Butrans patch. But Belbuca is also available in various strengths up to 900 micrograms twice a day. So I feel that with that product, you will come very close to some, to these other full agonist opioids, and yes, you can achieve very, very robust analgesia with that drug. There's no question about it.
If you use the, you mentioned the film.
Yeah.
Does that help with people that have severe constipation, severe gut immobility from taking oral agents, or doesn't it matter?
So another great question. So yes, there are studies that have looked at. I wouldn't say there was great studies, but there are studies that have looked at in commentaries. They have looked at buprenorphine in general in terms of it causing constipation versus full agonist opioids, and buprenorphine as a drug causes less constipation than full agonist opioids. And there's several reasons for that. They have to do with the chemistry and the binding of the receptor. But without getting into the science of it, one very practical consideration is that when you take an opioid orally, some of it is going right to the gut where the receptors are. But buprenorphine is not absorbed orally, and so you're not swallowing it. Right? If you take it buccally, it's being absorbed through the cheek, and if you use it transdermally, it's through the skin. So you're not dumping it directly into the gut to begin with. But even that aside, buprenorphine causes less constipation than full agonist opioids.
All by itself. Yes. Okay.
Yeah.
So if you had somebody with great difficulties, let's say, with the pills of buprenorphine, is it reasonable to switch to the film in order to address that problem?
Absolutely. And in fact, I actually, if you have a patient that's at high risk of respiratory depression, let's say because they're on benzodiazepines, the doctor's nervous about giving them with benzodiazepines, and there's good reason to be nervous, or they're on skeletal muscle relaxants or a combination, and they're on amitriptyline or a bunch of drugs that may cause sedation, the risk of being on a full agonist opioid is higher, right? So if you can achieve the same or better analgesia with Belbuca, and there's a plateau effect on the amount of CO2 accumulation, it's really a safer option. I mean, there's no question about it.
Excuse me, I'm losing my voice. You brought up the issue of benzodiazepines and narcotics together. This is becoming an enormous clinical problem. I got a note from one of the people on my tweet stream that the insurance company said, we're not going to renew your fentanyl patch because you're on Xanax. And I've been trying to find some literature that indicates that in the general population of people taking prescription drugs, that there's really been a problem of overdoses. The CDC data appears to be 95% from street addicts. The reason they could not study couldn't do studies for the 90 milligrams is because most everybody was a street addict. How are you going to get hold of them? So they commissioned some studies to look at how many people died from opiate-related deaths. And surprisingly, with looking at 5 studies, they all came up with very close to the same figure. And subtracting out suicides by pill, it appears that there's 500 people who die each year with opiate-related deaths. A pretty small number. So the question is, people are being yanked off the combination, and the combination is the traditional anesthetic combination of a benzodiazepine and an opiate. So the two, I think, and I was going to ask you, are they really synergistic? When people take a benzo with their opiate, does it make the opiate, does it increase the effectiveness of the opiate?
So the answer to that question is yes, without a doubt it does. And there's actually several articles that have looked at patients that are prescribed opioids and prescribed benzodiazepines And without a doubt, the death rate is far, far greater with benzodiazepines. There was also a great study that was done a couple of years ago in North Carolina, which showed, I think, close to 80% of opioid deaths involved the combination of opioids plus benzos. To kind of simplify the answer, benzodiazepines as a single agent do not cause respiratory depression. In fact, if you were on no other drugs and you took a benzodiazepine and you had no other medical problems, it is almost impossible to overdose on a benzodiazepine alone. Okay, but if you look at the CO2 accumulation from an opioid, there's always going to be some accumulation of CO2 with use of opioids. That curve is heightened when you add benzodiazepine. So a benzodiazepine as a single agent is not a problem. An opioid, when you combine it with opioids, yes, it tips the scale significantly and increases the risk of respiratory depression. Now, I agree with you that the insurance company should not be cutting patients off. This is something that needs to be, the benefits and risks need to be weighed between the doctor and the patient. But I also need to preface that by saying the risk is very, very much heightened by being in that combination. There's no question about it.
Now, is the risk heightened because people are found to have taken both drugs when they die? There's a significant number of people who take both drugs. So how do we know that it's really related to the deaths? What's the proof of the pudding? And were these done in addicts or were these done in regular old, prescription drug patients?
So there's been studies you can't study, post-mortem. Somebody's been abusing drugs and they've got alcohol, benzos, fentanyl, heroin. I mean, you're right. I mean, you can't use that data. But so a fellow named, I don't know if you know, Nabaran Dasgupta, but he led a study in North Carolina, and it was called Cohort Study of the Impact of High-Dose Opioid Analgesics and Overdose Mortality. That was the name of the study. It was in pain medicine, and I think that I'd have to go back and check the year, but I think it was 2015. And anyway, what they looked at 1 year in North Carolina of people using controlled substances by prescription, and looked at the mortality data. They had over 2 million patients, and the results were that opioid analgesics were dispensed to about 23% of the residents. The licensed clinicians, 89% prescribed opioid analgesic, and 40% of them prescribed extended release. Bottom line is that the opioids alone, when you factor out several issues, was very, very low. It was 0.022% per year. But 80% of the patients who received benzodiazepines, the mortality rates were much higher. So there's no question. I mean, this was in patients that were prescribed these drugs. There was no question that benzodiazepines have a higher risk. And this is in the population I think that you're questioning me about.
Yeah, the population in the North Carolina study was people taking prescription drugs. That study also showed a very, very small number of deaths in the 500 per year range nationally. We'll break that down for North Carolina. The number, it was a couple of hundred. And then they compared the levels of the two drugs without doing a full autopsy, without doing a psychological forensic post-mortem, which is you go look, you talk to people, you find out, what they were taking. The data is so small, they did not present any good statistics to show that the numbers were actually different. Because of the size of the study, I have asked people in the business of pain management for many years, a total of 125 years of experience. How many patients of yours overdosed in your clinical years? And the answer was none. There were a couple suicides, but no one in 125 years of clinical practice died of an overdose. So the overdoses in the population of medical patients is tiny. So the question is, because they then ranked the deaths with the dose without doing autopsies, I personally would not change my medical practice based on that study. And that's kind of my cutoff. If I read a study and it makes me change my medical practice, then it goes into the bin of good studies. That study got rejected because of its size and because they did not do full autopsies. People who die with benzos and narcotics on board could well have died for a lot of other causes, including heart attacks, strokes, arrhythmias. Because the number is so teeny for regular people overdosing, I think conclusions about what particular drug did the job is really suspect. But that's just my view as a country doctor who has to make these decisions about my practice.
So I agree with you that people that take their prescriptions as prescribed, the risk of death is relatively low. But let's just be clear here. This study was over 2 million patients. There was 478 overdose deaths, which was again very low. I agree with you, 0.022 per year. But the mortality rates increased gradually across the entire range of average daily milligrams of morphine equivalents, and 80% of the opioid analgesic patients also received benzodiazepines. And if you look at the rates of overdose death among the co-dispensed benzodiazepines and opioids, it was 10 times higher. It was 7 out of 10,000 person years with 95% confidence. So, yes, there could be other causes, but there's no question. I mean, 2 million is not a small number of patients. And other ones that died, clearly, being on the combination of the two, it was 10 times higher. I'll give you that. Let's say there's other causes. Let's say it was 5 times higher. That's still 5 times higher likelihood of death of not being on a benzodiazepine.
But there's a clinical issue as a clinician of 40 years that when somebody dies because they have high doses of opiates and high doses of benzos and high doses of lots of drugs, the question is, were they sicker?
Well, I mean, that's true. They may have been sicker. But, I mean, even in the conclusion of that study, they said that dose-dependent opioid overdose risk among patients increased gradually and didn't show evidence of a distinct threshold based on dose. So they agree with you with that. But they don't agree with you on the risk of benzos. So the risk of opioids across dosage range, even the higher doses, they didn't have a higher risk of death. It's when you added benzos at a higher risk. And in fact, a recent VA study showed that patients that had their opioid doses lowered had a higher risk of death, a higher risk of suicide. So I mean, you know, you can play around with these statistics, and you know, there's a lot of different conclusions you can come up with. And you know, I'm not dismissing what you say that they could have died from any number of reasons, but with that kind of confidence interval, I think that you have to believe that combining these two drugs elevates the risk.
So should we not treat people with benzos if they're on narcotics?
Well, I think it's a benefit risk kind of thing. If you have a person that's so anxious that you know they're going to jump off a bridge while they're on opioids, what good's that going to do? So I think it's a benefits versus risk thing. It has to do with tolerance. If the patient's on a reasonable dose of opioid, I think that, like I said earlier, a great thing to do is to switch them to buprenorphine, because the drug interaction is not as big of a deal between a benzo and buprenorphine because of the saline effect on CO2. So I'm not saying that benzodiazepines are contraindicated, and neither is the FDA, and neither is the CDC. They're basically saying that you should proceed with caution, not that you shouldn't take patients off benzos.
So now I looked up the interactions between benzodiazepines and pain medicines, and since they both cause sedation, the increased risk is more sedation. So if you're titrating somebody, first you titrate their pain medicine, then you titrate up on their Valium or Xanax, and there's no evidence of sedation, does that not indicate that things are going to be okay?
It does not. It does not, because if you do pulse ox studies, if you do oxygen levels, you can clearly show that if you infuse a patient with morphine, you can see their CO2 come down immediately. Then if you add a benzo, you can see the CO2 come down more. So sedation is not an indication of CO2 accumulation. It could be, but it's not mutually exclusive.
Well, CO2 accumulation causes hyperpnea and rapid breathing, so would that not be a symptom?
It could be a symptom, but these patients are not often symptomatic, especially when they're sleeping. If you have a patient with like obstructive sleep apnea and they're on opioids and everything seems to be fine, and you add a benzo, that risk is huge.
Well, that's somebody with another illness. That's a different story. We're talking about the regular old patients who benefit from benzodiazepines, maybe by boosting the effect of their analgesic effect of the opiates. And a lot of people in pain have really terrible spasms. They wake up with these terrible muscle spasms. Also, the drug, takes care of the regular old daily anxiety. And in talking to patients who are on these drugs, the greatest anxiety of all is waiting for the other shoe to drop. People lie awake at night afraid the next visit to the doctor is going to end up with them being cut off their medicine. I did a little informal poll and found out that a surprisingly large number of people are still spending sleepless nights because they're so frightened about what's going to happen next. So if they walked into a person's office with this much being awake at night, this much anxiety throughout the day, they would become an indication for benzodiazepines. And if we did not treat them with it, the question is, who would we treat? So patients need to be given odds. You're going to have the odds of, if you take these two together, you're going to accumulate CO2 and abruptly die in your sleep. That's a pretty scary thing to tell people. And the question is, if we have to give them odds, which is what I do in my practice, I give people odds. What are the odds if they took the two together out of 1,000 people, how many would suddenly die in the middle of the night with CO2 accumulation who did not have sleep apnea and did not have lung disease? I don't know. Would you offer a guess as to what it might be?
I have no idea. I mean, I could tell you that the percent risk is higher. I can't tell you exactly what that percent is. I think it depends on other factors. It depends on comorbid conditions. It depends on if they have asthma. It depends, as we mentioned, if they have sleep apnea. I mean, if they have none of those things, they still have risk, because, as I told you, there's some great studies that have looked at CO2 accumulation by adding a benzo. And there's no question about it that CO2 goes up. And there's no question about it.
Well, but people want to know, what their chances are. Should they avoid taking this and avoid the clinical response they get from opiates? I mean, from the benzodiazepines? I mean, as a clinician, I have to kind of tell people, this is common, this is rare, this is very rare. And so based on these studies, I mean, what kind of a category would you put them in for risk of suddenly dying at night, which people are afraid of? I mean, this would be rare or common or?
Well, I mean, if you want statistics, I can tell you that 80% of the people that died in the North Carolina study were on the combination of opioids and benzos.
And what percentage of people taking the two drugs died?
What percentage? I mean, so it was 80% of 468. That's a lot of people.
And 468 is a relative term. What percentage of the population taking these two drugs was that? Was it 10 million or 2 million? I mean,
can you repeat the question? I'm not
in other words, the 2 million people tracked were people who were on both drugs, correct? Or some of them?
No, that's not correct.
Okay, they were just tracking people on narcotics.
Right.
Okay, and then they looked at the people on the narcotics and benzos, and about how many of the 2 million were on both drugs?
I'd have to go back and read the study. I don't know. I don't know if they put that out. I don't know if they took too many patients and said, "Oh, those 2 million patients, how many people are in the combination?" I don't know if they did that. What they did is they looked at the opioids, and then they looked at the amount of people that died that were on the combination of the two.
Now, tell me about Xanax. It's never been a favorite drug of mine, and I'm kind of surprised there are so many people on it. One woman was telling me, look, I've been on this 20 years. It struck me because of its very short half-life that it might be creating its own anxiety in between pills. And I use as an example cigarette smoking. Nicotine's got a very short half-life. People smoke to relieve their nervousness, but the nervousness is coming from the withdrawal between the two doses of nicotine. So is that the case with Xanax, and should we talk to people about maybe switching to a longer acting benzo? They're going to get the same effect, correct? Whether it be short acting or long acting, but maybe we could avoid some of this. I really need this stuff. I'm nervous every day.
I mean, that's a good question. I think it depends on the patient. I mean, the half-life of Xanax isn't really that short. It's just over, the average is just over 11 hours. So you should be able to get 8 hours out of a Xanax dose. But I mean, you're right. Clonidine, for example, clonazepam, for example, has a very long half-life, and we don't get the peaks and troughs. The downside to that, of course, is that the patient may have a benzo on board when they don't need it if they have intermittent anxiety. So, I mean, I think it depends on the patient. Something like Valium or diazepam, I mean, that can accumulate over 40. Like you could have it for 40 days in your blood after you stop it because of the complex metabolism, and it gets metabolized to oxazepam. So I think I hear what you're saying, but I think that it's very patient specific. I mean, if I had a patient that had intermittent anxiety, they go 2-3 days and it's not a problem, and then something happens and they go all worked up, an occasional Xanax works for them, that's fine. If you're talking about a patient that has chronic anxiety and they absolutely need these things all the time, then I agree. Something like clonazepam would be a better choice.
Can you withdraw people from Xanax by putting them on Valium to help with the withdrawal? Yeah, because I've heard when people try to stop Xanax, it's a pretty nasty withdrawal. And can you help the withdrawal by putting them on simultaneous Valium to help cover the withdrawal symptoms?
Oh, I see what you're saying. I mean, I have at times, if a patient was to come off of benzodiazepine, let's say they were on Xanax, lorazepam may be even a better example, but they're on one of these drugs that's taken more frequently during the day. Yeah, I don't think it's a problem giving them something long-acting, but I would do is give them a low dose of diazepam and maybe have the dose of Xanax and let them take that PRN. So that's fine. I've actually done that, something similar with tramadol. So let's say I have a patient that comes to me on long-term tramadol, and I want to convert them, let's say, to an opioid, or not to an opioid. If for whatever reason I need to take them off of tramadol. So if you abruptly stop tramadol, as you know, they don't go through opioid withdrawal, but they can go through serotonin withdrawal. So what I do in some of those cases is I take them off of the tramadol, and I'll put them on Prozac or fluoxetine because it has a very, very long half-life, and like tramadol blocks the uptake of serotonin. So you can avoid serotonin withdrawal. Similar example, by giving a drug that has a longer half-life and stays around and sort of self-tapering.
Is there really a good clinical use for tramadol with all the problems that it has? Apparently, it's the only narcotic that FDA puts an upper limit on, not putting any limits on any of the other ones. Just what is your kind of personal opinion about the use of tramadol?
Well, the FDA actually does put a limit on tapentadol or Nucynta as well, right? So tramadol, I dislike that drug for probably the same reason that you dislike it. It's a sloppy drug. The parent compound has very little activity. It depends on the liver. For those listeners, there's an enzyme in the liver called 2D6, and 2D6 converts the tramadol to its active form, O-desmethyltramadol, and there's 5 metabolites. The next metabolites mostly don't have any usefulness. They cause a lot of side effects. So tramadol is a very, very weak opioid. It has 6,000 times less the binding affinity compared to morphine. And if you want to compare that to another drug that everybody knows and loves, that is the same mu binding capacity that we get from dextromethorphan or over-the-counter cough.
Right, cough syrups.
Right?
Yeah.
Right.
Okay.
So that's the opioid activity of tramadol. It's very, very weak. But because it blocks the uptake of norepinephrine, you get some synergy in the analgesic activity. But I think that because of all the potential side effects, the serotonin activity, the fact that we have to rely on the liver to convert it to its active form, the fact that depending on your genetic variability and your inherent ability to convert it to its active form, the potential for drug interactions by being on drugs that inhibit the metabolism of tramadol, it is a hot mess. And
so lowest on the list, perhaps.
I just think it's a very poor drug. Now, I've had some patients that come to me on moderate doses of tramadol on an as-needed basis, and they do fine.
Yeah.
And good for them. Good for them. But I try and stay away from it as much as possible.
There seems to be a myth going around amongst doctors that tramadol somehow is a safer drug in terms of all the things that we worry about, addiction and overdose. Is that not true? As a matter of fact, in the famous Krebs study out of Minnesota, where they said that Tylenol was as good as narcotics, they actually used tramadol in the Tylenol group, apparently not realizing that it's a narcotic. See, I think we need to get away from this term opioid. Then we'll all just call all these narcotics. It's a lot easier. But sure enough, they used tramadol, I guess viewing it as a non-opioid or non-something, and it still is a narcotic, correct?
Tramadol is absolutely it's an opioid for sure. It has opioid activity. There's no question.
Okay.
There's no about it. But you get me going on that Krebs. There was so many issues in that Krebs article. It was absurd. But yeah, there's no question it has opioid activity. But the opioid activity is weak. It's very, very weak. And so I think it's just it's okay in some patients, but it's very rare that I'll put a patient on opioids. But
So we can tell physicians that you can get addicted and overdose to this just as you can any other narcotic.
Well, you know what? So you can overdose, but the overdose is different. So people that die from tramadol overdose, they don't die from the opioid component. They don't die from respiratory depression of tramadol. They end up with serotonin syndrome. They end up with a seizure. Tramadol, people don't usually die from tramadol. In order to get kicks from tramadol, you have to take 30 or 40 tablets a day, at least.
Can you get addicted to it?
You can get addicted to it if you take very, very high doses. But again, to get addicted, to have physical addiction. In other words, you take the drug away and you have physical symptoms.
Yeah.
The bigger problem is taking away the serotonin.
Okay.
That's a much bigger problem.
Okay. So we agree, bad drug. Why prescribe it? And Dr. Krebs kind of tricked the general population by using it in her Tylenol group, and I think that's dishonest. And it was a VA-sponsored study, and the VA's got an interest in taking people off drugs. So, and it got wide press. It got, matter of fact, worldwide press. I've got articles from the UK and stuff that opiates are no better than Tylenol. I mean, that's a terrible thing to put out there. So I guess I will end the evening with that rant. And I think we're drawing upon the magic hour, and it was very nice of you to come and join us and give a pharmacist's view of the problem. Doctors do not rely on pharmacists enough. I've always felt that pharmacists are the ones that know about drugs. I mean, they got doctor's degrees or advanced studies, and to pretend like I know more about the drugs is really kind of silly. So I do rely a lot on pharmacists for information and helping to work out problems, just as we have been discussing pros and cons and things. And I think it would be nice if we figured out a way to have some roundtables with doctors and pharmacists about just regular old issues. For example, how much does it take to kill yourself with opiates by mouth? And how much of a nervousness should we have of combinations, et cetera, et cetera. So it was really nice for you to come to the show. I appreciate it. Thank you.
Well, you're welcome, and I think I speak for all pharmacists in thanking you for making those comments, because we all feel as though the education and what we have to offer is greatly underutilized, especially in this environment of this opioid crisis, where pharmacists who are therapeutic experts could actually be employed in doctors' offices and could bill to see patients if the federal government would give them provider status.
Kind of like they do in hospitals, right?
Yeah. Right. It makes absolutely no sense to me that pharmacists like MDs take their PCATs instead of MCATs for admission into the PharmD program. Instead of being an MD, they get a PharmD. And then most of them that want to do direct patient care do 1 or 2 years of residency and may do a fellowship. And people don't realize that even the pharmacists standing behind a counter in a community pharmacy have undergone that same education, but they've been beaten down so hard by insurance companies and all this other, how many prescriptions can you fill an hour. These people a lot of them have just given up. I mean, don't get me wrong, there's a lot of
that is really sad.
Wonderful.
And, we used to call the pharmacist doc. Hey, doc. Not anymore.
Yeah.
Because they do have doctorate level training and should be called doctor, I think. And if we want to nickname it to doc, that's fine. But that's completely disappeared. It's hi, Barbara. Hi, Jeffrey.
Right. Yeah, right. But anyway, we are all happy to work directly and collaboratively with physicians. And most states actually do allow for pharmacists to prescribe under collaborative arrangements with a physician.
Oh,
which
interesting.
is, I think, a good thing. Yeah, it's underutilized because they can't bill for those services.
Yep.
They do it.
And the two working together, I mean, there really is something about teamwork in medicine because it is not an exact science. So putting two heads together really is a valuable thing. And you're right. That's very interesting.
Great. Well, that's a good note to end on, huh?
Yes. And I got to say that I'm going to get a bow tie.
Okay. I'm going to hold you to that.
Yes. All right, Jonelle, are you around?
Yep, I'm here. I just wanted to say thank you to Dr. Jeffery Fudin for coming on and answering our questions. If we didn't get to your calls tonight, I apologize. Please feel free to either email me or you can call back next show, and we would be happy to answer your calls. And just a big thank you to our audience for taking some time out of your evening to join us here at Call Nation. I'm Jonelle Elgaway with Dr. Kline signing off until the new year. Have a Merry Christmas and a good night.
Good night.
This has been The Doctor's Corner with Dr. Kline and Jonelle Elgaway. Copyright 2018. All rights reserved.